Hello, my name is Victor Rodriguez. I'm a medical oncologist working at Sunnybrook Odette Cancer Center. I specialize in neuroendocrine tumors and their management, and I would like to thank the CNETS organization for this kind invitation. Today, I will be talking about COVID and neuroendocrine tumors. And we all recognize and we are aware of the pressure that the COVID-19 pandemic is putting in our healthcare system. And we do know that cancer patients are recognized as a vulnerable population. But first of all, we should know that, do we know that cancer patients are at risk of higher risk of contracting COVID-19 infection? I think that we have limited experience, and right now we should say that the risk is similar to the global population. However, cancer patients, including neuroendocrine tumors, are at increased risk of morbidity related to COVID-19 infections. And there are some established risk factors for that, including age greater than 65, the ECOG performance status, essentially meaning the general performance status of the patient, if the cancer is active or progressing, patients with lung cancer and other comorbidities are at higher risk of morbidity. With regards to the anti-cancer treatment, including chemotherapy, may not necessarily increase the risk of mortality. However, there's lack of evidence to define the individualized risk for a given patient. As I said, the relative risk of COVID-19 infections and its complications have not as yet been established in neuroendocrine tumors. However, there are some particularities within the NET population. Usually, neuroendocrine tumors, cancer patients are associated with increased comorbidities that can increase the risk of morbidity and mortality to COVID. We do know that some of our neuroendocrine patients may present with functional symptoms that can lead to consults to ER or to the hospital. There are standard treatment modalities in the neuroendocrine landscape that can increase the risk of immunosuppression and are associated with side effects such as infection, pneumonitis, or thromboembolic events that can facilitate the COVID-19 infection, but can also put on some diagnostic challenge. We, here at Sunnybrook, we conducted this report and this study, and this is a collaboration that we did with 10 countries and more than 13 specialized cancer centers in neuroendocrine tumors across Europe and Canada. And we published these general recommendations for the management of patients with neuroendocrine tumors in the COVID-19 era. So we do know that neuroendocrine tumors and patients with neuroendocrine tumors requires multidisciplinary approach. And we do know that each discipline has been affected with COVID. And obviously, neuroendocrine cancer patients are associated with some challenge given the rarity of the tumors. Required, as I said, specialized expertise, some limited access to some of the treatment and diagnostics. There might be some variability depending on the regional status of the pandemic, and there is a lack of data to guide our clinical decision process. And therefore, we should really implement workflows to minimize the risk of infections for neuroendocrine patients. As I said, maintaining multidisciplinary care for neuroendocrine cancer patients in the COVID-19 is a must. And there are some opportunities for adoptions of a what we call patient-centered virtual care. This allows us to start real-time video consultations, but still we are keeping some of the face-to-face consultation, particularly with when patients present with disease progression, or we need to discuss the goals of care, as we know that these face-to-face consultations are more empathetic. And again, risk and benefit of any particular intervention must be weighed on an individual patient level. Regarding testing, the COVID-19 testing, are we doing universal routine testing for patients? We are doing that here at Sunnybrook for those patients requiring admission, or for patients that are ambulatory but they are at risk of infection. And we do know that we should do the test within 24 or 48 hours of a determined treatment intervention. What is the management of the COVID-19 positive neuroendocrine patients? As I said, specific incidence, morbidity, and mortality of COVID-19 among NEN, the neuroendocrine cancer patients receiving oncologic treatment, is still unknown. Should we interrupt the anti-cancer treatment if we discover that the patient is positive for COVID-19? Again, we need to do a benefit risk assessment, and if we decide to interrupt the treatment, it should not be resumed until symptoms free and certainty of a negative virus. We should know that for those neuroendocrine cancer patients with functional symptoms such as diarrhea or flushing, treatment with somatostatin analogs are considered safe and should continue. What it is important is to establish cancer treatment priorities. Most of the treatment recommendations and indications in neuroendocrine tumors would fit under a lower priority following the Cancer Care Ontario category, meaning that essentially, as we know, majority of the neuroendocrine tumors are considered to be slow growing in nature, and the survival is not likely compromised if the treatment intervention is delayed. But again, de-escalation of care to minimize the risk of exposure and the effect of treatment modifications on NENs is still unclear. There are some treatment priorities, particularly for patients that are highly functional with uncontrolled carcinoid symptoms. Then the treatment intervention should be prioritized. For those patients with high-grade neuroendocrine tumors that behave more aggressively, we should continue chemotherapy. There are some indications for high-priority surgeries, such as for those patients that are highly symptomatic, or for those patients that potential delay in surgery would likely close the window of opportunity for surgery. With regards to some of the medical treatments, as I said, the somatostatin analogs are considered to be safe during the COVID-19 era. I think it is important to offer some alternatives, such as home delivery, options for self-injections. We can also explore different approaches, such as a watch and wait approach. We might consider increasing the dose of SSAs or the frequency for those patients that are slowly progressing, and that we are trying to avoid the use of a more toxic and aggressive intervention. There are other forms of treatments that are usually recommended for neuroendocrine cancer patients, such as sunitinib or everolimus. Although there's no specific guidance, they may be more favorable option than chemotherapy. But still, we consider that they're not of immediate priority. And the reason for that is that they are usually associated with increased risk of immunosuppression, diarrhea. There may be a risk for pulmonary side effects, such as what we call pneumonitis. There are overlapping diagnosis challenges. And if we decide to continue on that treatment, we should consider some sort of dose reductions or explore treatment breaks. Treatment with PRRT is usually considered safe here in Canada, but also our colleagues in Europe consider that this is a safe treatment, and usually is favored over targeted therapies such as everolimus or sunitinib, and chemotherapy if indicated. With regards to chemotherapy, there's no specific guidance. However, routinely withholding of anti-cancer therapy is not recommended. Again, we should do a risk-benefit assessment. And obviously, we should explore alternative approaches and discuss, for example, the number of cycles of therapy, exploring chemotherapy breaks after 4 or 6 cycles of chemotherapy, and obviously having a goals of care discussion is really key. Patients' preference must be factored into management during the COVID-19 era. We need to engage patients and caregivers with the most updated guidelines. We need to educate them on any deviation from the standard of care. We can facilitate care closer to home if that is convenient. We need to proactively manage the functional symptoms. We need to provide wellness interventions and supportive care needs, as well as psychological support. A few words with regards to COVID-19 vaccines and endocrine cancer patients. They're generally recommended, especially for those that are high risk of COVID-19 complications, such as those with cancer diagnosis within the last year, older than 65, or for those patients that are on chemotherapy or targeted therapies. The best vaccine is the first one that you can get, and they are considered safe for most of people with cancer. We know and we follow the provincial guidance that cancer patients get the second dose within 3 or 4 weeks of the first dose. And beyond the COVID-19 pandemic, I think it is important to develop strategies to mitigate the impact of the COVID-19 in neuroendocrine cancer patients. We should collect real-world information, including the incidence of COVID-19 within our population, on both patients that are on surveillance or on active treatment. That will allow us to characterize the clinical characteristics, as well as understand treatment prioritization and outcomes for COVID-19 positive and endocrine patients. And we should promote clinical cancer research during the pandemic. Thank you so much for the invitation.